As we already running late, I think without any more delay, we'll start the sessions. So let me, a small change in the topic. I think I'm going to talk on the cases we did today. We already made a presentation, so thanks to somebody for making a really fast presentation. So I'm just going to discuss no theories. We are going to just go through the cases we had today. Okay. We have 3 interesting cases we did today. Thanks to Dr. Sarantino. The first one was a case of a proximal AFib. The patient is with me for follow-up for the last 4 years. The last episode was around 3.5 years back. I kept him on flecainide. He basically was working in Singapore that time. So I kept him on flecainide. On flecainide he was doing well. He had a first recurrence on flecainide some 2 years back. I stepped up flecainide dose along with beta blockers, was doing well. Last 3 to 4 months that symptomatic episodes increased. He was complaining of more and more palpitations, and he had one documented episode some 2 months back. So we decided that we'll offer him cryoablation, and the patient was also willing for that. So we took the patient for cryoablation. Patient has a structurally normal heart. He had a mild coronary artery disease. LV was perfectly normal. LA was around 38 millimeter. So there is no dilated LA here, so normal sized LA. So we brought the patient in sinus rhythm to start with. When I started moving the catheter, patient started developing AFib. You can clearly see, I think you can recognize, you have a marker, point to the right. So you can clearly see, this is, whatever you see on the top, the 2 of them are surface ECGs, all below are electrograms recorded from the mapping catheter. So the first 2 ones are coming from surface electrogram. All these are intracardiac electrograms. We can see a clear potential here. This is a P wave recorded from catheter, the A wave. So atrial potential recorded here. You can see a kinetic activity here. This is the initiation of atrial fibrillation. So patient, the moment I started moving the catheter into the superior veins, patient started having a AFib. So it self-terminated. You can see here again patient returns back to sinus rhythm. The AF terminated and patient returned back to the sinus rhythm. So when we took a transeptal and taken the mapping catheter across the pulmonary veins. This catheter is now in the ostium of the pulmonary vein. You can see here, this is a surface ECG again. This is a recording from the coronary sinus. There is a catheter in the coronary sinus. You can see this catheter is recording an atrial electrogram and a ventricular electrogram, and I am placing the coronary sinus here to see the pulmonary vein potentials. You can see this is a catheter which is kept in the pulmonary vein. You can see here clearly some spiky potentials which follows this potential. This is a normal atrial electrogram. After atrial electrogram, you can see a spiky potentials here. These are the potentials which we call them as pulmonary vein potentials. These are the potentials which are arrhythmogenic and which connects into the atrium and creates trouble for you, causing a atrial fibrillation. So this is pulmonary vein potentials recorded from the catheter. So we put a cryo balloon into the pulmonary vein and started freezing. You can clearly see here the first potential and second potential is getting a delay here. So this is the initial thing which happens when we freeze or do a radio frequency. You are trying to dissociate a pulmonary vein potential from the atrium. We know very well that's a excellent paper from Azagray which clearly says, which they identified, the most common triggers from AF comes from pulmonary veins. So in AF ablation, the most important step in achieving sinus rhythm or keeping the patient in sinus rhythm is having a pulmonary vein isolation. So you have to isolate electrically pulmonary veins from the left atrium. This is the basics of AF ablation. So this we were doing for a long time. I think maybe Dr. Sorrentino was doing from 2004 onwards by doing a radiofrequency ablation, which we call as a point-to-point isolation. So we take a catheter, which is 4 millimeter tip. We do a one point-by-point ablation and try to electrically isolate pulmonary veins from the left atrium. What cryo offered was, when cryo came in, you have a balloon which fits into the pulmonary vein ostial area, and you deliver cryo energy, and in a few seconds it can isolate the pulmonary vein completely. So here you can see the balloon is in. We started delivering the freeze. When we started delivering the freeze, you can see the pulmonary vein potentials are getting delayed from the left atrial potential, showing that we are causing some amount of isolation of the pulmonary veins. So you can see here, slowly you have lost the pulmonary vein potentials over a period of this is now the balloon is in the left superior pulmonary vein. So slowly the left pulmonary vein is getting isolated. You can see here, see these two beads, these are the pulmonary vein potentials, but they are no longer associated with the atrial potentials. So atrium, left atrium and pulmonary veins are isolated completely. You can see I am pacing the atrium at a particular speed. You can see the interval between them. Now the interval is not at all correlating between the pulmonary vein potentials. That means these pulmonary vein potentials are no longer getting connected with the left atrial potentials. This is what we call a pulmonary vein isolation. So at around 34 seconds of freeze, the pulmonary veins got isolated from the left atrium. So what we usually do is, the moment we see a isolation, now we have to make sure that there is no more connection between these two areas. You can do an entry and exit blocks. You can pace from the coronary sinus and put a catheter in the pulmonary vein and see this pacing potential gets conducted to the pulmonary vein, or you can pace from the pulmonary vein and see that that potential comes to the left atrium. We call it as entry and exit blocks. Here you can see here, I am pacing the pulmonary vein potential, but it is not connected to the coronary sinus electrogram. The coronary sinus is going on its own rate, while we are trying to pace pulmonary veins at a separate, faster speed. None of these potentials have gone into the left atrium. So this pulmonary vein is already got an exit block also. So we have isolated and we have proven that there is no more connection between the pulmonary vein and the left atrium. This is very important. This is a step which is going to determine patients how long he is going to remain in sinus. As long as we are able to isolate the veins completely, one great advantage of pulmonary vein isolation with cryo balloon is the consistency and the level of isolation remains over a period of time. There are enough and more data which shows that if you are able to achieve these kind of isolations during a procedure, this isolation is going to stay. When the patient comes with AF, after some time, if you go in and see, you will see that pulmonary veins are already isolated. This AF, what you see after 4 years or 5 years, maybe a trigger coming from somewhere else, the pulmonary vein remains isolated once you have done a good cryoablation of the pulmonary veins. So you can see here, I have put an exit block here. So the same way we went into the left inferior pulmonary vein, we are trying to isolate. You can again clearly see a spiky pulmonary vein potentials here. But in spite of freeze, the first freeze was not working. So we have to readjust the balloon. So we have gone for a second freeze here. You can clearly see here. You follow here, you can see a spiky potential here, spiky potential here. Suddenly when you reach here, you no longer see a spiky potential which is following your atrial potential. So this LAPV also got isolated with the freeze. So again, we are going into the right superior pulmonary vein. So when you go into the right superior pulmonary vein, we are again seeing a pulmonary vein potential. One thing you can see here is there are two pacing I am doing here. One is I am pacing from the coronary sinus. Another, there is a spike here. This pacing is done from the SPC. We try to capture the phrenic nerve, because the phrenic nerve comes closer to the right sided pulmonary veins. So one of the known complication of a pulmonary vein isolation with a cryoablation is a pulmonary phrenic nerve injury. So avoid a phrenic nerve injury, we continuously pace the phrenic nerve and try to capture the diaphragm. The moment there is a weakening of diaphragmatic contraction, we usually stop the freeze immediately. This phrenic nerve injury is also common with radiofrequency ablation. The advantage here is what we have seen from a large data of cryoablation, most of the time it's reversible. Even though you have caused a phrenic nerve injury, it is reversible in most of the patients. The permanent phrenic nerve injuries very, very uncommon, very rare. So here I am facing the diaphragm, capturing the diaphragm. So I am delivering the freeze here. So you can see here again, there are a lot of potentials which you are seeing in the pulmonary veins, and it's completely gone. In one fine movement at around maybe 25-30 seconds into isolation, the pulmonary veins have become silent. This is a sign that pulmonary veins have got isolated. So you are no longer having any signals recorded from the pulmonary veins. So you have got a RSPV also isolated. This patient, RSPV was the one which was firing. I think when I was moving the catheter, the RSPV was the one which was triggering the AF persistently, more recurrently. So that RSPV also isolated now. So again, we are doing RAPV freeze. Usually the order which we do is start with left superior, we go with left inferior, then we come with right inferior and right superior. The reason being, right inferior is the one which comes close to the phrenic nerve. So by chance we have any phrenic nerve injury during the time, we have to stop the cryo. Then if you have already not completed a RAPV, then you would have lost one vein without an isolation. So if you go from RAPV to RSPV, by chance if you have some amount of phrenic nerve injury, you can always hold on, so that already you have isolated the three veins completely, and other vein also have some amount of an isolation. So this patient again, we have gone with the RAPV freeze. So again, RAPV also got isolated. So in this patient, all the patients we had, three of cryos we had today, all three of them got a CT scan done before. So you can see we have got a CT image of pulmonary veins, and this is an image of pulmonary veins which are created by the 3D system we have. So the advantage with the having a CT scan is we can superimpose this image to the CT scan picture. Our EP system has a capability to merge the CT into the mapping system. So you can see that the CT image got merged. That means you no longer have to look in fluoro to move your catheters. You have a proper image of left atrium with you. So you can see here, you can see the catheter, mapping catheter, which is seen in the superior vein, and the signals are recorded from the mapping catheter. You can clearly see where my catheter is moving by looking at the image. So again, you can see, I think it's not very clearly visible. You can, this is the one isolation what we got it. So you got an excellent isolation here. If you watch carefully, you will see a lot of pulmonary vein potentials here, and completely everything is absent here. So this vein is getting isolated here. So this is a magnified view. You can clearly see pulmonary vein getting isolated during it. You can see our catheter, the mapping catheter is in the pulmonary vein. My cryoballoon is here. So cryoballoon is on the vein, and the mapping catheter is recording from the pulmonary vein. So you isolate, there will be no conduction across the pulmonary vein into left atrium. So this is a short video of what we are doing. You can see the catheter here. We have started the freeze, and slowly you can see the pulmonary vein potentials are lost. You can clearly see here there are pulmonary vein potentials. Once we started the freeze, the pulmonary vein potentials have completely disappeared. So we have done a map of the left atrium. So you can see the pre-freeze. There are a lot of high voltage areas which were seen in the pulmonary veins. So we have ablated that. You can see grey colored areas, which shows that you have already isolated these areas. There are no more voltages recorded from these areas, suggesting that we have completely isolated all the 4 pulmonary veins. So this is how the fluoro looks like. You can see here, this is the sheet which we use for entering the left atrium and take the balloon across. So you can see here the balloon is into the superior vein, left superior vein, the mapping catheter inside the pulmonary vein, and the balloon is well opposed on the pulmonary vein ostium. The advantage with cryoballoon is, unlike a catheter, the one problem we always face is you don't want to go into the pulmonary vein to ablate. There is a possibility of pulmonary vein stenosis, and you have a phrenic nerve injury, esophageal injury, all are more common when you go inside the pulmonary vein and ablate. By which you have a large size. This balloon comes with a 28 millimeter balloon. It's very unlikely it's going to enter the pulmonary veins. So it stays at the antrum level, so you can deliver at an antral ablation. Antral ablations are recommended for AF ablation. So by virtue of the size, your balloon stays outside the pulmonary vein, so you deliver an antral isolation in most of these patients. So you can see here, the balloon is moved to the different veins, and every vein you are getting the balloon getting opposed to the pulmonary veins and you deliver. The biggest advantage with cryo balloon remains the rapidity at which you can achieve pulmonary vein isolations and the speed at which you can do the procedure. The AF ablation, one of the biggest problem with the AF ablation remains the duration of the procedure. You have to create a good radio frequency ablation and isolate a vein. You may end up doing a procedure for 4 to 6 hours. Every vein may take close to 45 minutes to 1 hour to isolate. But in cryoablation, once you are able to go across the septum, you got a transeptal access, it's a 180 seconds freeze in every vein. So it's 3 minutes each in this vein. So all the procedure together, if you have a reasonably a good anatomy, you may end up a procedure in 45-50 minutes, skin to skin. So that saves you a lot of time, and we know, being a cardiologist, the lesser you stay with the patient inside the lab, the lesser the complications. So the less, particularly left atrium is not that forgiving chamber. We know a small issue with the left atrium is usually difficult to control. It's a high pressure, thin wall chamber. So you stay little there, you are in a systemic circulation. So you stay longer, you tend to create thrombus. So thromboembolism, all are very common if you are going to stay longer. Cryoablation brings down the time of the procedure dramatically so that you can give a reasonably good isolation in most of these patients. The advantage again is when you do a complex AF ablation. Maybe you have a patient whom you have to do a lot of ablations, including you have done a PVA, you have to do a lot of substrate ablation. PVA remains the cornerstone of AF ablation. So if you can deliver a cryoablation PVA for 25-30 minutes, you have a lot of time left for you to do other ablations if required to do in left atrium. So that also makes your procedure more successful, because you have another 2.5-3 hours time, whatever time you want to have spent, you do further lines, further roof lines, you do a posterior lines. So you have enough time to do other work in the left atrium if the patient has a big substrate. So this was the second patient. This is approximately, this is a doctor. He has approximately for the last 5 years, multiple episodes. Unfortunately, he could not document most of the episodes. He developed palpitations. When he has a palpitation, he tries to go to the hospital, take a ECG. He could not document it. Sometimes ago, when he, with an Apple Watch, he could document a few episodes of atrial fibrillation. So he came for a ablation because he was really symptomatic. So again, we went with LPV, left pulmonary vein. You can see a huge potentials here. When we started ablating, say completely dissociated potentials. So you have completely dissociated the superior vein from the left atrium. So again, RSPV, you can see here, we are seeing huge pulmonary vein potentials here, and completely isolated, maybe around 35-40 seconds of freeze. So you can see here, this is a good electrograph to see. You can see here, there are 2 catheters are inside the heart. One catheter is in the coronary sinus, another catheter in the pulmonary vein. Both the catheters are recording atrial electrogram. You can see here, this is the atrial electrogram, but you can see this atrial electrogram is much slower than this atrial electrogram. These both electrograms are dissociated from each other. What we usually see, what we call it as a dissociation, you can see very clearly here, this electrogram is completely dissociated from this electrogram. That clearly shows that this pulmonary vein has been completely dissociated, isolated from the left atrium. So whatever happens in this pulmonary vein will not come into the left atrium. So RAPV, you can see here, is completely signalless. You can see only a flat signals here. It's completely isolated here. So this is what we did. So this catheter is positioned in the branch of a pulmonary vein, and we isolated, giving a good cryo balloon freeze, and patient had a excellent isolation post. This is a third patient. It's a very interesting patient. He has a young 45-year-old male. AF for last 1.5 years. He was started on flecainide. He's on flecainide, etraxaban. He comes from Middle East, so he's on etraxaban, Novak. Multiple episodes. They stepped up flecainide, they stepped up beta blocker, they added amiodarone. Nothing could control his AF episode. he presented to cath lab in AF. We can see that when the patient came to the cath lab itself, he was in AF. You can clearly see a chaotic activity in the electrogram which is suggestive of an AF. So this man had a predominantly firing coming from a superior pulmonary veins. So you can see a huge pulmonary vein potentials here. When we started to freeze, this is a pre-freeze left superior pulmonary vein. So we started freezing here. So we started pacing and we started freezing here. You can already see here some delay in the pulmonary vein potentials, and slowly we are getting a delay. And you can see a loss of pulmonary vein potentials here. You can see one potential here which is not conducted to the left atrium. You can see one pulmonary vein potential here which is not connected to the atrium. So this pulmonary vein is completely isolated. So we can see clearly when we started tracing and capturing this pulmonary vein potentials which never went in. So there was a clear exit block of pulmonary veins. So this is again a right superior pulmonary vein. You can see a huge pulmonary vein potentials here again. So again we pace here. You can see here we are pacing the diaphragm here and we are isolating. So there's a complete isolation here. You can see there is no signal recorded in the pulmonary veins. So this was, it looked like, you can see the posterior wall of left atrium. The grey areas are the areas where we have not recorded any voltage. So the pulmonary veins at the level of nearly angstrom, they are isolated from the left atrium. This is one of the biggest advantage of cryoablation. Cryoablation, unlike radiofrequency ablation, we know radiofrequency ablation delivers around 4 millimeter sized burns. So when you make a line across, what you have made is a 4 millimeter line across the antral area. But because cryoballoon delivers a larger lesions, you can see larger area of posterior wall of left atrium is already isolated. We know very well from our experience that most of the substrate for persistent AF also remains in this area. So when you are able to do a PVI with a cryoballoon, you tend to take care of some amount of substrate in the posterior wall of LA also. This is the one reason pulmonary vein isolation by cryoablation has a effect which is more than what you expect doing a pulmonary vein isolation. So these are the cases we did today. Very interesting cases. We are very thankful to Dr. Sarantino for being with us and getting an excellent result from all three patients. I think all three patients are highly symptomatic. Fortunately, all are PAF, proximal AFib with a normal LA. Hopefully, they should remain AF free for their life. Thank you.
Thanks, Lawrence. I think couple of questions. These patients who were on medications prior to going in for for cryoablation, how long do you stop these medications, or do you really need to stop them? Because anyway, you're going to isolate the pulmonary veins. If the focus is from some other point, do you really need to make sure that he's drug free before he comes to the lab? And if so, how long do you require that?
I usually, as you already told, because what we've already decided doing a pulmonary isolation. Right now, most of the places across the globe, the protocol is simple for managing AFib. If you have proximal atrial fibrillation or early persistent or late persistent atrial fibrillation, the primary strategy is going to be a pulmonary vein isolation. If it is a pulmonary vein isolation, the cryoballoon offers the best pulmonary vein isolation results. So for that, you need not stop the drugs because you don't have to induce AFib in the lab. Anyway, unlike other arrhythmias like AVNRT or AVRT, we go inside the lab, induce the arrhythmia, find out where they are coming from. Now here we have decided, and by our science available right now, we know that pulmonary veins are the prominent triggers for this AFib. So pulmonary vein isolation, you don't have to stop any drug. What we do, and otherwise, we usually keep these patients maybe 1 to 3 months on anti-arrhythmics, because the early period, what we call the blanking period, because if you have a successful PVA also, it takes around 2 to 3 months for the lesion to mature to create a good isolation. So until that time, we usually continue anti-arrhythmics. So patient, we don't stop anti-arrhythmics in between.
Nice presentation, Lawrence. Two issues. One is, can we take all patients without drugs straight away for cryo number one? Number two, what is asymptomatic recurrence rate and symptomatic recurrence rate?
See, the first question, I think now there's a big evolving concept in atrial fibrillation that any atrial fibrillation has to be tackled as early as possible. Because AF, what we see is a progressive disease. So what you see as a proximal AF at some point of time is going to become an early persistent and permanent AF. So if you are able to catch your patient at a period when he is in proximal AF, there's a high probability that you will stop his AF becoming a persistent or a permanent AF. So now HRS recommendations are like if the patient is on drugs, cryoablation is as good as drug. Comparing both to efficiency, better than drug, it offers an efficiency, but complication rate, what side effects of drugs are as good as cryoablation. So cryoablation as a primary strategy of managing atrial fibrillation is emerging. You may not have to wait for your drug to fail before going for an ablation. If you have a patient whom you have seen a atrial fibrillation more than an episode, even though you feel like he is controlled with drugs, you can go for an AF ablation because he is not going to be controlled by drugs for a longer period of time. At some point of time, he is going to relapse from the drug, and when you are going to go in and do that time, your success rate is not as good as if you have done earlier. So the early referral for atrial fibrillation is what evaluating now. Second is success rate, symptomatic and asymptomatic recurrences. I think PAF with cryo has a success rate more than 70%. There are data which are available right now where they have done a loop recorders implants. Again, your success rates are in the range of more than 70 to 80%. Even with the asymptomatic recurrences, like patients has no symptoms at all, but you have a loop recorder recorded, so it records. So there are some patients who with a pacemaker go for a AF ablation, so you can easily pick up AFibs. So the success rates with the PAF is definitely more than 70%. The advantage of cryoablation is the consistency of success rate. Radio frequency ablation, the problem comes is the learning curve and your volume. To achieve a reasonably good result, maybe the result which Dr. Sorrentino achieves may not be replicable in every lab which does an AF ablation, because your numbers have been so huge to achieve a good result with radio frequency ablation. Cryoablation, learning curve is shorter, and that consistency of success from multiple labs, from multiple electrophysiologists remains same, because technically the learning curve is short and not so challenging procedure. So the consistency of achieving a sinus result is much higher with cryoablation.
And Dr. Arun, you mentioned about the atrial size. Now what happens if it's slightly dilated atria? Like, see, many of them are long-term hypertensives. So the LV function may be normal. Because of diastolic dysfunction, atria may be slightly bigger than normal. So does your success come down, or is it just a technical issue in doing the isolation in such a scenario?
The marker for atrial remodeling is atrial size. So what we see as a atrial size is what happened to the atrium over a period of time. The patients who have a larger atrium tend to have more scars. So usual limit I use for most of the patients is 45 millimeter. Any left atrium, maybe to start with, there are people who go with 50 millimeter LA also. So 45 millimeter and above, I usually be little doubtful to the patient when I'm explaining. But as you said, that not be the only criteria. The left atrial dilatation may not be precursor for left atrial scarring and remodeling in all the patients. There are few patients who may have a little larger left atrial size and still can have a good results from a ablation. The problem with advantage, I would say that when you have a larger left atrium, the procedure becomes a little simpler basically. Like the transeptals are easier, moving catheters become simpler, because these are like the today's patient, all the left atriums are around 35 millimeters. The transeptals becomes a little difficult because puncturing transeptal punctures in a smaller atriums are a little difficult, and manipulating catheters in the smaller atrium is difficult.
And second thing, is it guidelines has it not yet come for cryo?
Yeah.
What is the class of recommendation?
So right now it's class 2A, right? For cryo as a primary ablation strategy. So I think Dr. Sorrentino was part of the trial Stop AF. I think she will be able to give us more data on that.
Excellent presentation, sir. What is your experience on the recurrence of AF after this cryoablation, sir? Any cases you have seen?
So it's too early, like I think cryo is in India for 6 months, 8 months. So we've just started in India doing cryoablation. So whatever data we have is from Western literature, but cryo, the number of cryoablation done is like enormous now, like huge numbers have been done across global. It's available for close to 12 to 15 years now. So
the meta-analysis also.
a lot of data is available, like a single operator experience itself is huge now. There are operators who have done 10,000s and 20,000s cryoablation as a single operator. So the recurrence rates are in the range, like what you achieve with cryoablation is as comparable to radiofrequency ablation. It's around 70 to 80% you can achieve a long-term sinus rhythm in most of these patients if you take them early. I think we are talking, whatever the data we are talking, is an era where still today also we had a discussion, like even in US the referrals are delayed. So if you are going to get a patient early, your results are going to be much better now. So whatever data we get right now are on delayed patients.
There was an article recently in JAXA you might have come across. For drug-naive patients, the immediate treatment goes in for cryoablation.
Yeah.
That was the recommendation.
Yeah, that's what coming up now.
Yes.
Like, that's what I was telling. Like,
Yes.
that's where we are heading now.
They have done a study with 300 odd patients and they have found it was very useful when the patient initial treatment is a cryoablation.
Yeah, that's where we are heading right now. Like cryo being a primary strategy, like even on drug-naive patients.
Thank you.
Thank you, Lawrence. I think we've been running a little slow on this, so we'll go on to the next part of it. The only thing I think, really, when you see, earlier it was the symptomatic who come back to you saying that there is a recurrence. But with the Apple Watch and all these things, you're going to see a lot of asymptomatic patients who come with very short intervals of AF recurrence. And I think it's going to be a big question whether you want to treat that or not treat it. 1 minute, 2 minutes, is that adequate? Are there guidelines to say what is the duration that you would say, okay, this is you need to go in again for a repeat procedure? Maybe we could deal with that during the next half of this session. So let me close this session and then maybe we'll listen to Denise for the second part of it.
So then we will move on to the next talk. Thank you. So let me invite Dr. Dennis. I think what is
Just overview on cryoablation.
So it's going to be an overview on cryoablation. Thank you.
First of all, I'll say thank you for having me. I was thrilled to make this trip and the visit. And I'll say today, spending 3 cases with Dr. Lawrence's lab doing their first 3 cryos, I am so impressed with your facility. I'm so impressed with Dr. Lawrence and all the staff that are trained in that lab. They were excellent, absolutely excellent. The staff that assisted during the procedure and the mapping staff, it was just top notch. And to think like this is early on, our first cases. So yeah, cryos come a long way. I started doing my first AFib ablations with radio frequency in the early 2000s, probably about 2004. Those radio frequency AFib ablations were, at that time, we did something called WACA, which was wide area circumferential ablation. That was preceding any mapping system, preceding any CT imaging that we did for it. We weren't able to segment it and enter it into our procedure at all. And at that time at least, we provided our own sedation, meaning as the operator of the radio frequency, you delivered your own sedation during the procedure. So it was kind of like I'd be working until the patient expressed pain or started moving. Then I had to, with one hand, hold on to the ablation catheter, with the other hand, pull up some sedation and deliver it through one of the sheets. Of course, that was never very good. Early on in AFib ablation, just like we had great questions earlier, early on we had a lot of partners, cardiologists, even other electrophysiologists in my practice. In my practice, we have 9 electrophysiologists who would question what is the use of AFib ablation. You know, atrial fibrillation has been, of course, one of the difficult diagnoses in cardiovascular disease to treat. It's the #1 cause of a silent stroke or thromboembolic stroke. For many people, it leads to either heart failure with preserved EF, HFpEF, or systolic heart failure. And many people are symptomatic. The current criteria for doing an ablation for any patient, and by the way, there are still people in the US that do radiofrequency ablation over the cryoballoon. Again, like with everything, there are different levels of adopting a procedure, but we always recommend doing it on symptomatic patients. And so, you know, there was a question earlier, when do you decide to do another ablation or decide even to do a single ablation? And I agree, in the US, we have more patients with home monitors. Either they're Apple phones, they're Samsung phones, or there's a small metal device that's very inexpensive that I recommend my patients use called a Cardia Mobile, that's under $100 that they can have, record, download to their phone or their iPad or laptop and send my way. And so the question is, what's the quantity? Dr. Lawrence probably has already told you that Heart Rhythm Society decided many years ago, probably like 2002, 2003, to call a recurrence or an occurrence of atrial fibrillation of 30 seconds. So, you know, a lot of us EPs who do AFib ablation, we don't like that definition of 30 seconds because sometimes patients will have monitors, either their home monitors, outpatient monitors, 30-day monitors, or ILRs, and they'll record 30 seconds of completely asymptomatic AFib. So currently, we recommend in our practice doing ablations, first ablations, or repeat ablations on symptomatic patients. So if you have an ILR in or you have a pacemaker in and you had 60 seconds of AFib and you had absolutely no symptoms, first thing we would do would be a Chad's 2 VASC score, see what your risk for stroke or mini stroke is. And again, we use that 30 seconds or greater to determine who should we anticoagulate. You know, if their has blood score and their Chad's 2 VASC score indicate anticoagulation, we're pretty quick to anticoagulate people. And then we determine symptoms. And if someone states they have absolutely no awareness or no symptoms, we look to see if it's at night when they're sleeping. And as many of you know, and again, Dr. Lawrence is so on top of things, obstructive sleep apnea can lead to atrial fib. And so if we see nocturnal only, brief, asymptomatic AFib, we get the sleep study. Often we will do now, during COVID, at least the American Board of Sleep Medicine has approved home sleep tests. And I'm not sure if you're doing HSTs here now, but it's great. It comes in a small kit. Patients don't have to come to sleep labs. They go home, sleep with this oxygen prong, wristband, finger band on, and bring the results in, and often we could diagnose sleep disordered breathing and have an apnea-hypopnea score on that, so we always look for that. But for the most part, we try to really treat symptomatic patients. It's true, I was part of, and my practice was part of the Stop AF First trial, which was presented in New England Journal of Medicine 2 years ago now, which actually showed, as far as symptoms and patient side effects, there was actually a superiority to AFib ablation first for paroxysmal atrial fib. In the U.S., the same here in your country, the problem is that we often don't see the paroxysmal atrial fibrillation patients. You know, even for me, beginning in the early 2000s, all the way through 2022, a lot of paroxysmal atrial fibrillations are being treated by patients' primary care physician, emergency room physician. They leave on maybe diltiazem or a beta blocker. Hopefully they started on a DOAC. But we're trying to change that whole way of thinking to really see electrophysiology first. Of course, we're not going to ablate every single AFib patient out there, but we'll assess symptoms, risks, and really determine whether the patient would benefit from an ablation before extensive amount of drugs are taken. We all know that antiarrhythmic drugs have side effects, And so although an AFib cryoablation, a risk of complications in the 2 to 3% range, and under skilled hands, as people do more and more cases, that risk drops to the 1 to 2% range. And so the risks are, as pointed out earlier, just difficulty with the transeptal puncture that could lead to pericardial effusion or tamponade. We anticoagulate before the procedure. I keep my patients on DOAC. I just usually hold 1 dose. Then they're on heparin throughout the entire procedure. So although they're anticoagulated, there's still a small risk during a PVI ablation, even with cryo, of TAA or CVA. I have never seen it during a case, but it can happen. During cryoablation, like any other ablation, there's risk of esophageal injury. We measure temperature in the esophagus the entire time, having either anesthesia or a staff member move the probe to the level of the balloon, but there's still a risk of esophagitis. A lot of studies done early on in RF and cryoablation saw some patients with esophageal breakdown. The worst outcome is something that, again, you've all probably heard of, and this again is what scares some physicians and patients away, but it is a left atrial esophageal fistula. Of course, we don't want the contents of our esophagus entering the left atrium or vice versa. That can be a life-threatening complication. Again, in my practice, I've never seen it, but I'm monitoring very closely esophageal temperature, coming off cryo or RF when you have precipitous drops for cryo or rises with RF, and then being aware if patient complains of fever, difficulty with swallowing, and a lot of chest pain early on, an urgent CT scan and treatment is necessary. Often now, when this occurs, and again, I haven't seen it in my practice, but they will put a stent in the esophagus to help cover that fistula area. As I was speaking to Dr. Lawrence, I do use proton pump inhibitors after all my ablations for 1 month. If the patient's already on a proton pump inhibitor, that's great. And then finally, the injury to the phrenic nerve. That can occur during radiofrequency or cryo. And as Dr. Lawrence said, they state in the literature the recovery rate's nearly 100%. I've had a few phrenic nerve injuries early on in my cryo days. And please understand the balloon is better than it ever was. We've learned so much more, including not using a very small balloon like we once did, which often can slip into the vein. And as Dr. Lawrence said, you never want to ablate in the vein. First, you could cause pulmonary vein stenosis, but secondly, that phrenic nerve, if you're going to freeze the phrenic nerve, it's usually if you're in that vein or getting really cold in the vein where it transmits right to that phrenic outside the right superior pulmonary vein. So we've learned the Germans initially stopped using the 23 millimeter balloon, and then in the US we stopped. And there are rare circumstances that that's an exception. The fact is, it's easily tolerated. Currently, due to pandemic in the US and our limitation on beds, for the past 2 years, my practice, not just me, but all of my partners, we use a venous closure device called Vascade, which is a small plug that sits outside the vein, not in the vein, to close off our access sites. And my patients go home 2 hours, 2 to 2.5 hours after the procedure. So it's great. I mean, it's really becoming an outpatient procedure. I'm not absolutely sure how the structure is in your country, but certainly it's less beds being utilized for patients with this procedure, more beds for other critically ill patients. And I think that even here, it can be evolved once Dr. Lawrence is comfortable letting people go home the same day, because they really do that well. You know, they usually do low level of activity for the first 2 days. If my patients are laborers, home builders, roofers, street workers, I keep them off work for 1 week. Otherwise, most of my patients are back to work later that week. So it's really pretty amazing. The technology has grown because we now have 3D mapping, because now we have great ways with the Achieve catheter, which he showed you those recordings where you can see when the pulmonary vein blocks. First of all, it makes people believe that it's actually doing something and working. And secondly, we can be assured that we could limit the amount of lesions we're giving and limit the amount of procedure time to the patients, because we can see this all happen. In the early days of cryoballoon, there was no reporting Achieve catheter. We just had wires. So it was more like doing the entire ablation of all 4 veins, then checking things things afterwards with a mapping catheter. So the beauty of adopting this procedure now in 2022 is we're on a second generation sheath, we're on a second generation balloon, we have 3D mapping, and your medical center is so lucky to have such great mapping and staff that can do the mapping. And so you're already on the fast track for extreme success. And so the real issue is I agree with him 100%. I still see a lot of referrals that are persistent. Other cardiologists or primary care physicians thought, well, I thought this patient was doing fine on their flecamide or propafenone or even amiodarone. But, when you talk to the patient, you look at the data, they potentially have been in. I definitely ablated patients who probably have been in atrial fibrillation 6 to 12 months, but maybe weren't seen or thought that this was the way it was going to be. It was really amazing for symptomatic atrial fibrillation patients to get the veins isolated, to get them back in sinus rhythm, and then I usually at 3 months will stop antiarrhythmic, even in the persistence, do monitoring, and if they stay in sinus rhythm, I don't reintroduce antiarrhythmics. Certainly for people that have been on toxic drugs like amiodarone, we need to try to get them off those drugs because that is truly an organotoxic drug. And then if they do end up on a less toxic 1C agent, when formerly they couldn't stay in sinus on amiodarone, and now we just have them on a low-dose propafenone or flecainide, that's still a major win. So when you're dealing with those persistence, we can't always get everybody off all their drugs. As far as chance 2 VASC scoring, usually for my patients, if they have a score greater than 2, I'll tell them even after the ablation, I would recommend staying on anticoagulation. Now we have a lot of patients that have scores less than 2, and a lot of patients who say, I know that that's my score, but I don't like taking anticoagulation due to my job or my pastimes, risk of bleeding, falling. There's a lot of people who are doing manual labor or even extreme sports who wish to be off their anticoagulation. And again, a lot of them, if they have their home monitoring devices, their watches, their cardias, we could use that information to assure things. So I even do get some people off anticoagulation, but I promise nobody that I will be able to do that. But I think for people with symptomatic AFib, it's a big game changer. If recurrences are 30 seconds or greater and completely asymptomatic, I don't think we have to go back for a second ablation. As Dr. Lawrence and I were speaking, atrial fibrillation is a multiple trigger disease, right? We have PV potentials, and I was telling him, I always tell my patients the morning of their ablation that I'm going to do the easy part. I'm going to be able to get in, cross over, and eliminate all PV potentials. And not everybody just has 4 veins. I've seen over the years patients with 5 veins, 3 veins. We had a left common pulmonary vein today. I've had patients with a right and left common simultaneous pulmonary veins. But I always tell them eliminating those triggers, that's the easiest part of their treatment. They'll go home later that day, they'll feel great. There's all the rest of the risk factor modifications like we see in coronary disease. If patients don't do their part on that, they're going to be at higher risk for recurrence. So those include hypertension. Poorly controlled hypertension is an independent risk factor for recurrence of atrial fibrillation. So really getting home blood pressure readings, 120s over 70s to 80s. There's just no way around it. Number 2, diabetes, blood sugar control. Hemoglobin A1C is a direct correlate with recurrence of atrial fibrillation. So we have a prevention group within my practice that works with getting patients with a diabetic educator, getting them on the proper diet, and getting the hemoglobin A1C down. BMI, so body mass index, which is a major issue in some areas of the United States, is an independent risk factor for recurrence of atrial fibrillation. So like even after your coronary intervention patients, speaking to them about weight loss and heart healthy diet and whatever we need to do to help them bring their BMI down. Valvular heart disease, if they have significant mitral or aortic insufficiencies, that may lead to more difficulties with recurrent atrial fibrillation. So getting them on the proper drugs for afterload reduction or anything else Certainly some of our patients get mitral clips or other procedures on their mitral valve if that's a major issue. And of course, sleep apnea. So sleep apnea, treating sleep apnea with CPAP, BiPAP, or I currently, for mixed apneas that have a large component of central, I'm putting in the pericardiophrenetic vein pacing. So, we go to such great efforts not to injure phrenic, but actually there's a nocturnal central sleep apnea system now, a small device, to pace the phrenic nerve at a low level, not something that would wake the patient up, but to treat central or combined apnea. So there's so much new out there for sleep apnea that those all need to be addressed. But certainly waiting for someone, I used to. Many years ago, I tell my patients, well, we shouldn't really do the ablation until maybe you lose at least 10 or 20 or 50 pounds. That just doesn't work. And remember, people who are having AFib are so symptomatic that a lot of times they don't feel like exercising or doing anything. So I don't make anybody wait anymore. Number two, waiting for CPAP to be ordered or for them to begin treatment for their sleep apnea. That's a long-term process. And if we wait a year or 6 months for them to use CPAP, to wait to order a consultation with Dr. Lawrence for a PVI ablation, they're still waiting too long. So again, it's almost like we don't want to penalize patients. And I think one of his patients today at an outside institution in a different neighboring country, they said, well, we're going to first treat your sleep apnea, which is great. It should be treated, but you should also get your veins isolated. So the Stop AF First trial really brought to the forefront that offering PVI ablation for symptomatic atrial fibrillation, one occurrence or more, was appropriate because the risk of the procedure with the cryo balloon is so low. Procedure time is low. It's not a zero risk, by the way, but it's low. And the benefit is greater with less side effects than people who are starting, one antiarrhythmic after the other. And I'm sure you've had those patients. You might start with a 1CH with flecainide or propafenone, and I'm not sure how much sotalol or dofetilide is used in your country, or amiodarone. And patients are having symptoms, side effects, drug-drug interactions. So I think really, and there have always been a lot of naysayers when it comes to PVI ablation. Even one of my now retired EP partners would say, I don't believe it works. I don't believe it. But when you're able to see great data and electrograms, this was a day with 3 cases where, there's no doubt about it. Those PV potentials, they're gone. The patients for the first 8 weeks may go in and out of AFib. We call it the healing phase. But their atrial fibrillation either will be gone or dramatically reduced. And when we looked at the early AFib trials, which were mainly paroxysmal, but some persistent, and select out the paroxysmal only, the results look more like 85% of patients have significant reduction, instead of like the actual data from the early studies with cryo balloon was 73 to 75%. But if we look at those patients with the more normal, quote, sized atrium and true PAF, the results are even better. And so I think that, we've always had naysayers in this area. Now it's just harder to refute it. Plus the technology is good, the safety is up. I mean, I'll bet the safety is even, greater now because we have so many ways of watching things. I encouraged Dr. Lawrence today to do a technique that I started with a physician who's now in Utah many years. I'll say it was maybe end of 2011, early 2012, where he can even inject contrast during these cases. A little puff when he went transeptal, but usually when you would occlude the vein with the balloon, 2 of my partners still inject contrast to make sure that there's no leak. But today his excellent staff, immediately, and it took my staff a few weeks, set up a left atrial pressure line that recorded left atrial pressure with an A and a B wave, which is kind of, elementary cardiology. And then when we occluded the vein, the pressure rose, we lost our A wave, and we knew we were occluded. That's another step to increasing the safety profile of this procedure. So in a way, you all may think, or he may think, too bad I couldn't have had this technology in 2011 when it was first, out there and getting moving after the study was published, December of 2010. But I think actually now is the time that we're really ready for prime time of this procedure. And for his lab to do 3 in a day, I've only once had my lab do 3 in a day. I usually do 2 PVIs and an SVT, or 2 PVIs and a IVI-CD. And if I told the staff I wanted to do 3 a day each time I did cases, they would groan, because sometimes room turnaround takes a while, getting the next patient ready. You know, they have a lot of patches that we use for 3D mapping, takes a while. But I'm so impressed this lab did it 1, 2, 3. I mean, really very impressive for first time around. So anyway, kudos to everybody. I do have a slide set. I will say this is like a very extensive slide set, but some of this is really good data that probably everybody knows. I advanced for the morning. Now my advancing stopped. But there's a few good slides in here. I'm more for trying to talk to you about everything and get questions answered. Yeah, I did it. I paged down for a while and then it suddenly stopped. Maybe. So persistent AFib, this is excellent for persistent AFib as well. You know, we kind of have a differentiation in my practice where we call it early persistent versus late persistent. But I've got to tell you, a lot of really desperate patients come to me with late persistent AFib and with left atrial size of 5 centimeters, 50 millimeters. They're big atrium, they're persistent. And quite amazingly, by isolating pulmonary veins, we still can do a dramatic improvement in their atrial fibrillation burden. Again, it might not go to 0, but a dramatic improvement. Furthermore, a lot of patients with persistent atrial fibrillation are on toxic drugs like amiodarone, or drugs that are expensive like dofetilide, Ticacin. And having an ablation and getting off those drugs is also a huge plus. This is talking a little bit about complications, and again, we are doing everything we can to do that. Maybe I'm pressing them too quickly. Oh, there it goes. The team approach for this is absolutely key. There's a new balloon. So, again, the balloon has gone multiple changes since its release in 2010, early 2011, but the current balloon has more ports for freeze. It's easier to get it in a stable position, and again, this is a huge advantage of the adoption at this stage of the game. We talked about all of those possible procedural risks. You know, and here he showed you some live photos of the balloon, but it's true. We don't want to do any type of ablation, maybe this isn't clear, with the balloon in the vein. And the true fact is, by the size of this balloon, it does give not only vein isolation, but the tissue, that antral tissue surrounding it, which is super important for even patients who end up having persistent. As an off-label use in the US, we are still trying to find ways to do more substrate for some of the persistent patients, where we will keep the Achieve mapping catheter in the vein, but rotate the balloon and deliver some freezes outside it to get a larger area ablated. And although today he showed you a great image where that posterior wall, which often is the second most likely spot to have a lot of electrical activity for recurrent atrial fibrillation, he showed you on his patient is just a thin strip of activity. With a few more freezes in a persistent patient, often I can make the entire posterior wall go gray. The problem with doing that with the catheter is often there's gaps in those lines. And so I think we had spoke together earlier today about something called left atrial flutter. For patients who've had previous radiofrequency isolation of the veins, if there's a gap in the line, it allows for an area of reentry and rapid arrhythmia that can cause very fast arrhythmias. Usually if patient states, when I was in atrial fibrillation, my heart rate was only 110, these left atrial flutters will easily hit 140, 150, even 170s, and they're very difficult to treat with drugs. You know, even like halotricuspid isthmus flutter, you know, even on drugs, people have recurrent flutter. Well, these left atrial flutters are just bears. And so the beauty of doing extra ablation with the balloon or antral ablation with the balloon, it's not like there's a gap or an area where a circuit can reform like it does with radiofrequency. Today we talked about and did all of the issues with alignment. You know, there is certainly an element of finesse with the balloon, using various fluoro image or 3D mapping images to make sure that the balloon fits right and fits correctly to get the results that we want. The transeptal, again, you're very lucky, Dr. Lawrence clearly is skilled at transeptals. And so some users, when AFib ablation began, were just starting to learn transeptals. So having that technique down is something that they're used to is super important. Sorry, I don't know why it's flashing on and off like that. It's playing a live screen and it's flashing on. So today, we did treat a common vein. So again, common veins are not uncommon. And a lot of times the staff will, you know, run and tell me, well, this patient has a common. I've had patients that have even had anomalous veins that empty into the right heart. There's always a way to approach all the pulmonary veins as long as they have potentials that need to be ablated. And so again, this is, you know, some of these details are more for the user. The great news is technology is available. These images are for intracardiac echo, which currently this lab does not have. It's not essential. I mean, I certainly learned and did my ablations without intracardiac echo for a long time. Because the lab I work in now has it, I do use it. But today we did all the cases, had left atrial pressure to prove occlusion, and everything went very smoothly without having that extra bit of information. So again, a lot of the extra information is useful, but I think if people approach it in a very organized way and use the tools that you currently have in your lab, which is a great Matic system, a great you know, fluoro with good, very good imaging, the simple left atrial pressure monitoring, and then watching for isolation, that's really all you need. So I don't know if intracardiac echo is on Dr. Lawrence's wish list, but it's a non-essential. You know, I told him, once I started using it, when you cross the interatrial septum, you get a lot more details, especially the stretchy septums, the aneurysmal septums, the lipomatous septums, the hypertrophied septums, the calcified septums. And, you know, sometimes we've even had to use, you know, different techniques to even RF across the septum. That maybe is more likely in a redo, but all the transeptals today went smoothly, and you don't need that technology. But with intracardiac echo, even though you had left atrial pressure monitoring, you still can use color flow Doppler to look for leaks. Oh, it's on the screen again. I think the video, yeah. Where's those? But you could use the color flow Doppler around the balloon to look for leak. Today we had my most challenging vein, which is, I shouldn't have said it to him yesterday at dinner, but the right inferior pulmonary vein can be challenging to get the balloon approximated. And sometimes if you have intracardiac echo, you could tell where your leak is from. But the fact of the matter is, we got the vein isolated. We were able to do it without that technology. So really the great thing about cryo is you don't need a huge amount else other than the cryo, good transeptal skills, the ability to watch and see each vein ablate, and then safety measures. You know, checking ACTs every 15 to 20 minutes, making sure the patient's anticoagulated, And then today, I really will say, I was really impressed how comfortable the patients were. I think he did a great job preparing the patients. Although I used to deliver my own conscious sedation during ablations, we had some younger partners join our practice a few years ago who would only do their PVIs under general anesthesia. So like 98% of all of our PVIs were doing with general anesthesia, which in some ways actually increases the risk because they can have risk from receiving general anesthesia. And so I just can't wait to go home and tell my partners that people are doing it here with conscious sedation. The patients did just great. In the early days when the cases were much longer, it was hard for the patients to lie still. And as you can imagine with the mapping system or a balloon inflated in the left atrium, we really don't want people moving a lot because we don't want our patches to move. We don't want any equipment to accidentally puncture the posterior wall of the left atrium. We just don't want any complications. But I believe in these 3 procedures today, nobody was moving, period. A little discomfort, it can be uncomfortable when the balloon gets really cold. Often people will have chest pain. And then when we're pacing the phrenic nerve, it's like a hiccup every few seconds. But as long as someone's aware that they're not hiccuping, we're pacing that nerve to make sure everything's safe. These patients did great. So I think kudos to him to really have prepared these patients because they were ultra cooperative. And we currently are on, my practice has 137 AFib ablations waiting, backlogged due to the pandemic when a lot of the elective procedures couldn't be done, and now we're waiting for anesthesia to help us get them taken care of. But truly, again, today's cases proved we really still can do this with conscious sedation or even MAP. I mean, I don't think these patients received high doses of sedation. They did great. The first gentleman I was able to say hello to and speak to afterwards. And again, that's usually what most patients want. Even if somebody doesn't want pain, a little bit of medication, I mean, we would probably use a little bit of fentanyl or propofol at the time of balloon freezes, maybe all we need. So summary is this procedure is excellent. It's been proven by multiple studies over the course of many years. His take home was correct. The sooner we see the patients, the better. When I first started doing AFib ablations, all I was referred were persistent AFib patients. 1 year, 2 years, 3 years. Our results are not good. We need to see patients early. And again, that doesn't mean, you know, someone in the audience is sitting thinking, I had AFib once for 2 minutes, or post-op gallbladder surgery, I had AFib for 20 minutes. But truly, atrial fibrillation that's symptomatic occurred once or more. Getting your veins isolated is going to save you a lot of medications, doctor's visits, emergency room visits, and sending those patients early. The results will be better. You know, I think even the fact that we were doing so many persistent AFib patients early kind of gave it a bad reputation because, you know, patients would say, well, my niece had an ablation. Of course, that was SVT, and she never had a problem after. Why am I still having problems? So I always tell patients, you know, everyone's so different, and even people who have siblings who have AFib, everybody's risk factors are different, everyone's left atrial size is different, everybody's duration is different. But certainly, I never advertise this as a cure. It's really not, it's treatment. But if I had a choice of having a PVI ablation or taking medication for months or years, I definitely would do an ablation. In 2022, the safety profile and the results absolutely are better than having drugs. So hopefully your community will consider sending him patients. If his lab did this well with the first 3, I can only imagine what they're going to do with the next 3,000. It'll just be like rolling right through. So thank you, sorry. The slides didn't work, but really I think his images with the cases today, it's a picture is worth 1,000 words. And when you see those veins isolate and you see the loss of potential, there's no arguing with that result. And the thought that these 3 patients will be coming off antiarrhythmics in a few months is even better. So I'm here to say kudos to this program. I'm coming back tomorrow to do 2 more cases, then we'll be moving on. But I think a lot of people in your practices and in your country will be thrilled with the technology and these results. Thank you. I'll stay here for questions.
Thank you. Yeah, so thank you and very nice cases today. I have a quick question on the phrenic nerve. How do you actually, how today, like how did you monitor the phrenic nerve? Does it mean, I mean, sometimes the recordings we get a lot of noise on the diaphragmatic potential. So do you need someone stand there and have their hand on the phrenic nerve, or can you go by the potential?
Yeah, so there's so many ways of doing it, but this is the way we usually do it. You know, the old way to do it is to have your hand or your elbow. In the early days, again, things are just so much better. I used to put my elbows there and hold everything with my other two hands. And anyway, we don't want phrenic nerve injury. You know, if somebody does have a phrenic nerve palsy, they're dysmic. And if they come out and aren't having AFib, but they're really short of breath, that's just terrible. So I usually always have a hand feeling it. And with a good capture from our catheters, I used to use a bipolar EP pacing catheter, and it was hard to get a good phrenic capture. Now we use a multipole EP catheter and pace off a larger area, usually poles 1 and 4 or 1 and 5. We get such great phrenic capture. We also have adopted a handful of years ago, I'm going to say maybe 6 or 8 years ago, something called compound motor action potential. We call it CMAP. We're actually ahead of, again, when the staff are prepping the patient, they put a little electrode near the right-sided diaphragm away from the mapping patches, and we're actually able to see an action potential on our screen below the EP potentials for the pulmonary vein that is the diaphragm when it's being stimulated. And before you lose palpated capture, if the CMAP, compound motor action potential, starts to diminish, we come off. And the staff know that that's a double click off or a press and hold, which is an intentional deflation of the balloon, so we don't continue to freeze the phrenic nerve. So actually the compound motor action potential is a great way to capture phrenic nerve starting to get too cold before it actually stops jumping or stops capturing. So, and again, I kind of assumed today that maybe they wouldn't be set up for CMAP. They were totally set up for CMAP, and we had CMAP during these cases. And so we watch both. You know, the pacing, and believe me, none of these patients today were morbidly obese, so like the whole table kind of shakes with the phrenic pace. And the CMAP was right on the screen for us. So it's two great ways. CMAP, we'll see the change first, call off, or just loss of capture. And you know, even when you're on your best game and you call off quickly, sometimes I have found a patient could have maybe 30 seconds of loss of phrenic capture, but usually if we catch it on a CMAP, we come off quickly, we usually can recapture that phrenic nerve within that case so that we can complete the ablation. So I think we've gotten excellent at doing that. That being said, I find tall, slender females still to be the highest risk group of temporary phrenic paralysis, just the way that that nerve runs, especially right outside the right superior vein. So we're just ultra cautious. But again, in my experience, I've had a few over 11 years, and they've all recovered. The first one was with a 23 millimeter balloon, and I stopped using that balloon because, again, that could sneak into an enlarged vein, and if you freeze in the vein and capture that phrenic, that's going to be the tough one to get to reverse. But like, no one does that anymore. So again, Dr. Lawrence benefits from all of the experience and the modifications that a lot of users have had over the years. So today they had CMAP and we palpated the phrenic, no problem.
So, how about the recommendations right now for cryoablation? Where we stand on guidelines and recommendations for cryoablation? when the patient exactly gets referred or will be planned for a cryoablation for a patient who was in the first episode of AFib, or patients who are naive on antiarrhythmics, and patients who are relapsing on antiarrhythmics, where we stand.
Yeah. So currently, we're recommending for paroxysmal, persistent or early persistent, but paroxysmal patients, based on the STOP AF first, it is first-line therapy. And I told him in the U.S. we're doing some private pay insurance companies are not recognizing that as first-line therapy. So the only reason why some patients may not get it, I still reserve it for symptomatic patients. Most patients are symptomatic. Now, symptomatic doesn't mean they feel the AFib. That's not symptomatic. I mean, it could be symptomatic. The symptomatic also is they feel fatigued. When they're in AFib, they are short of breath. So symptomatic doesn't mean awareness of. It just means that somebody's feeling poorly. Short of breath, dizzy, lightheaded, fatigue, unable to work, unable to focus. So currently, we're recommending a cryoablation after the first or second episode if patient has symptoms. Now, the completely asymptomatic patient, remember, this isn't a mandatory procedure. So if someone has had 1 or 2 episodes, and I see these patients, I talk to them about an ablation, and they'll tell me, I feel fine. I do not feel bad, and I would never do that. You know, some people don't want to have an invasive procedure. When I consent my patients, I let them know the risks are small, but I go through the potential risks. And some patients say, if I feel good, why should I have to do that? And they don't have to do that, so they don't. So I think symptoms still remains in that recommendation. So if people are found and really feel that they're feeling fine, they're willing to take a direct oral anticoagulant, and they have decent rate control. I also like to tell them that, you know, atrial fibrillation begets atrial fibrillation. So the more you have, the more you're going to have. And we hate to wait until it's persistent for you to come in and say, I can't get out of the chair, for us to say, okay, we'll do an ablation. Although we should have done it 3 years ago when it was paroxysmal. So the sooner the better. And so we're recommending this is a first-line treatment for people who've had 1 or more episodes of atrial fib. And again, the results are much better with small left atria, not a lot of comorbidities. So yeah, I mean, we're out there recommending it. And I'm finally at the point where I'm getting the emergency room physicians to refer me patients. Because they're often the ones that are seeing the patients first. You know, not necessarily other, because once they get to a cardiologist, it's likely that they're going to be gone on a direct oral anticoagulant, maybe beta blocker, calcium channel blocker, and I'll see you again in 3 months or 6 months. And we kind of want to see them before then.
Ma'am, after this ACE-TAF-NET trial, do you expect a change in recommendation? That's my first question. My second question is, many physicians, because there is no mortality benefit with AF,
Yes.
they don't refer the patients. Rather, they have a hesitation. What's your best reply to those?
Yeah.
Nice
Again,
news.
this is why we do it for symptom control, right? Fatigue, dizziness, lightheadedness, feeling poorly. We don't have a mortality study. There is not a mortality study. And so that's why, you know, unlike recommending somebody a stent with a critical coronary lesion, I can't tell you that you're going to live longer if we ablate your AFib. This is purely to improve QOL, quality of life. And so, you know, everyone wants to live a better life. I mean, I think the 3 patients who came in for their ablations today had symptoms. Palpitations, weakness, fatigue, dizziness, felt unwell, and wanted to do something about it. So certainly, I never tell anyone that you'll live longer if I ablate your AFib, that's for sure. And then the first part of the question was which study? I'm sorry. Yeah. And so, you know, a lot of the trials are looking at AFib and different options, different different outcomes from the ablations. And so I think that currently different modes of ablation are still being used, and not every study is a cryo study. But you know, we're even starting at our institution trials with pulse AF, but that pulmonary vein isolation ablation is going to remain like the forefront of this. And And I'm not sure if I addressed your question completely by that.
Just a couple of questions to you. Very impressive results, and it's almost like a result like an angioplasty.
Yeah.
So the issue remains, how often have you done in a given patient, the number of times that you have done?
Yeah.
That's the first question, and the second thing is, we also hear about, if this is not successful, we will do a posterior wall isolation and all that. So is there a role for posterior wall isolation in the context of cryoablation? And do you think this radio frequency is outdated now with the cryo?
No, so first, how many ablations will I do? 2. Rarely there's been a third. Now, the exception is if ablation's been done elsewhere and people have left atrial flutter, or if I go in and find that the veins were never isolated. I mean, it's amazing, especially early days of the AFib ablation with cryo balloon. First generation balloon only had 4 ports. If you didn't do a really extensive job, those veins reconnected. So first ablation, pulmonary veins, isolate them. Number 2, if they have recurrence, bring them back, check the veins. Sometimes we'll find a leak. A leak is just a small area of reconnection of a vein. We take care of that. Then the next is, we don't know, we still don't know. And a large meta-analysis was just published saying, back in the old days, we used to do something called cafe ablations, complex atrial fractionated electrograms, and we put them into AFib and look for these fractionated electrograms and ablate there. You might know that there's data from software called the Firm software and rotors. This is another almost magical way of doing AFib ablation where I would go to these conferences and watch the rotors and I could convince myself that I saw them. But not everyone in the world was convinced, and those studies could not be reproduced, so the rotors kind of fell off. Radio frequency ablation is still preferred by a lot of